present the case.
A 35-year-old farmer presents with complaints of fatigue, lethargy, tiredness, and dyspnea on effort and palpation. For last 6 months, he has
Palpitation.
palpitation. Palpitation. For the last 6 months, he has difficulty to swallow food but eats mud. On examination, pale flat nails, angular stomatitis found to be positive. BMI is 18, pulse rate 100 per minute, blood pressure 150/70, respiratory rate 20 per minute, temperature normal, no lymph nodes, no bleeding spots or bone tenderness, a grade 3 systolic murmur over the base of the heart heard. A murmur is heard over the neck as well.
With this brief history of 6 months, what are the possibilities that you consider in this case?
Sir, with the presenting symptoms of fatigue, lethargy, dyspnea, palpitation, etc., this could be anemia due to. Also, there is said that the person eats mud, so this points to an eating disorder of pica, which is usually associated with severe anemia.
Okay. Are there any other possibility in relation to fatigue?
Fatigue can be due to hypothyroidism can cause fatigue, then chronic in case of malignancies.
Can you get fatigue in simple straightforward mitral stenosis?
Mitral stenosis can cause fatigue.
Heart failure?
Yes, sir. Heart failure, chronic heart disease can cause.
Hypopituitarism?
Yes, sir. Hypopituitarism can cause.
Hypoadrenalism?
Yes, sir.
Myasthenia?
Myasthenia can cause fatigue, sir.
So it is a non-specific complaint. And
Yes,
he has got palpitation and dyspnea. Okay.
Palpitation, yes, sir.
How do you explain his difficulty to swallow food?
Sir, can be due to the obstruction in case of esophageal webs can be caused in Plummer-Wilson syndrome associated with anemia. So due to the webs there can be obstruction and food doesn't, it finds difficulty to swallow.
Looking at the examination findings, you would like to say each finding, how do you explain that with your diagnosis?
Sir, the nails are found to be pale, which shows chance of anemia, and also angular stomatitis can be found associated with nutritional deficiency.
Yes, sir, but this patient's nail is flat.
Yes, sir. And there is no spooning. Mildening.
Early cases is like only flat, subsequently becomes spooning.
Yes, sir.
Okay, then carry on.
Angular stomatitis can be found in nutritional deficiencies like B12 deficiency, folic acid, iron deficiency, etc. Then BMI is here normal, so rule out other malignancy or diseases like that. And usually in anemia there is tachycardia and hypertension. Tachycardia can be seen, and there is tachypnea.
How do you explain the blood pressure 150/70?
It can be due to hyperdynamic circulation can be found associated.
Okay. So, and coming down, how do you explain the murmur? The two murmurs described here.
There is a anemic murmur of anemia. There is an ejection systolic murmur at times associated with it due to the increased flow. So
Yes.
this can be due to the murmur, or there can be ring dilatations due to the insufficiency.
Okay, and another murmur over the head of the neck.
Usually it is aortic stenosis is the murmur radiates to the neck. But here can be a functional murmur. Likely.
Does a functional murmur radiate to the neck?
Unlikely, sir.
Unlikely. So you have said your possibilities. One by one you have said. Now let us see what these are the possibilities. Why do you say it is not CI esophagus?
First of all, this is a young patient and there is no other history that's pointing out to malignancy other than tiredness. There is no weight loss or anything like that is mentioned here, and the lymph nodes are negative, not palpable. So chances are unlikely.
Before analyzing dysphagia, it's difficult to say because age itself cannot be the only factor to say that it is esophagus carcinoma or not.
Okay, sir.
Usually it occurs in people who are smokers or alcoholics. Also the history of regurgitation, GRD, acid-peptic complaints.
Yes, sir.
Iron deficiency anemia you already mentioned. Is iron deficiency anemia common in male patients?
Since this person is a farmer, there can be a hookworm infestation and all, and there is malnutrition can be present in this patient. So not enough iron in diet.
Can the murmur be because of aortic stenosis?
Yes, sir.
Okay.
The radiating.
Can this be venous harm in the neck?
Can be possible.
Can be possible. So all possibilities remain.
Yes.
Okay. So your explanation for the symptoms you already given. So
There's
dysphagia, stomatitis you said, dyspnea and palpitation you said. So you explained the symptoms. Okay. Now the dysphagia you rightly said can be esophageal web, it can be carcinoma. Stomatitis you said it can be deficiency.
Yes, sir.
And you already said dyspnea is because of anemia.
Yes,
okay.
Sir. Yes.
Right. Now, how do you analyze a case of dysphagia? This patient has got dysphagia. How do you arrive at a diagnosis from the history?
There can be a mechanical dysphagia more to solid or.
Just a minute, Johns. Everybody else to go to the mute stage. Extraneous sounds are heard. So everyone is requested to go to mute stage. Only Johns will speak. Okay, carry on.
We need to check from the history whether it is more to the solids or fluid. Like in mechanical obstruction, initially there won't be problem with fluids, but dysphagia will be more to the solids.
Good.
But if it's neurological, that is oropharyngeal causes, then there can be fluids will be difficult in the initial stages.
Okay. Any other point?
Aspiration and can cause dyspnea and pneumonia, etc. So
that's complication, no?
Complication.
Okay. So, okay. So dysphagia is analyzed in a very step fashion. Step 1, anatomically, where do you localize the lesion? Which are the locations where you can have dysphagia due to? Which are the locations?
In the oropharynx
and esophagus
itself.
How will you differentiate between the two?
We can do, first of all, from the history, like I said, fluid may be initially difficult more in the case of oropharyngeal, and in investigation we can do an endoscopy.
Okay, wait. So oropharyngeal dysphagia is differentiated from esophageal dysphagia because when you ask the patient, where is your dysphagia, they will point to the pharynx with their finger. And they will say, it is the difficulty to initiate the swallowing. Once it goes down, it goes smoothly goes out. And when they attempt to swallow, they get cough and choking. And it is these group of patients who get nasal regurgitation. You rightly said it is worse with liquids and solids. And obviously it is more common with neurological diseases. On the other hand, if you ask the patient with the dysphagia, with the esophagus, patient will point the finger to the sternum.
Yes, sir.
And they have no difficulty to initiate the swallowing. It goes down the throat, then it gets stuck soon after swallowing. Okay?
Okay.
And it is worse with solids than with liquids. There may be history of reflux or otherwise.
Okay.
And symptoms will be commonly more progressive in course of time. So these are the points to differentiate. 6 points are there to differentiate oropharyngeal and esophageal. You have answered very well. Okay. Now come to the, how will you recognize mechanical cause of dysphagia?
We can do a barium swallow.
Okay, that's good. So we think about mechanical causes in people who are slightly elderly, male patients with history of heartburn. They may be having some stricture there.
Okay, sir.
Okay, lower and dysphagia kind of stricture because they can have history of heartburn, weight loss, and it is more with solids. So you think it's a mechanical one. How will you recognize esophageal dysmotility disorder?
Manometry. We can check the pressure whether the sphincter is.
Yes, yes, Johns. We are discussing clinical case, not investigation. Okay, don't worry. So it affects both solids and liquids. So minute, small points in the history may help us to narrow down the differential diagnosis.
Yes, sir.
Okay, so if there is a esophageal dysmotility from the history, then you investigate for that. If there's a mechanical obstruction, then you go for endoscopy or barium swallow. Like that, you have to go clinical. So analysis of dysphagia rather than investigation of dysphagia. Okay, how does this dysphagia progress? It asks histoprogression.
With progression, it will be difficult for more for liquids.
Okay. So if the patient says rapidly it is progressing, then few weeks, months, it is more suggestive of malignancy. But if somebody is saying intermittently dysphagia, always think about myasthenia. But if it is progressively, non-progressively intermittent, think about esophageal web. Okay. What does odynophagy indicate to you?
Painful swallowing.
That's the meaning. What's the interpretation?
There is stricture.
Odynophagia means there is pain that indicates inflammation. So that's pointing to esophageal inflammation called esophagitis.
Okay, sir.
It may be because of chemical esophagitis, infections like candida, infections like herpes. Okay, all exotic things can come that indicates esophagitis. Okay. What are situations where people say very bad pain in the chest, just like myocardial infarction pain when they swallow food? Unbearable.
Associated with GERD.
Especially when they swallow hot or cold, some people have excruciating pain in the intestinal area.
Ulcers.
So when you have this type of unbearable pain, think about spasms. Esophageal spasm is a peculiar entity where you can demonstrate corkscrew shaped esophagus and the barium. Okay. Achalasia and systemic sclerosis are two other conditions where you can have the same problem. Now, can you tell me some conditions where you take some medications, doctor prescribed medications, and you get esophagitis? What are those pills?
NSAIDs, bisphosphonates can go.
Bisphosphonate, excellent. Yes, tetracyclines are well known. Okay. So, how do you prevent this bisphosphonate-induced esophagitis?
We should not take it in the supine position before bed. Should be only taken when we are erect.
And preferably the empty stomach. That's very good. Okay. So you have analyzed the dysphagia. So whenever you have dysphagia, just jump to investigation. There are a couple of points by which you can say, is it mechanical, oropharyngeal, esophageal, is it neuromuscular, or is it a motility problem, or is it spasm, or only inflammation. Accordingly, we can proceed with the further analysis of the case and investigations. Okay, so we have a couple of drugs producing esophagitis. Now, you have also explained the signs. Okay.
Yes, sir.
So, you said systolic murmur is possibly functional. So, when do you say a murmur is functional?
Usually, it may not be associated with thrill, and radiation will be usually absent.
Okay, correct.
Usually found in hyperdynamic situations.
That is correct.
Then mostly base.
What is meant by base? What will be base?
Broad,
Where's the base? Base of the heart.
broader portion. The broader portions.
Which part? Which part is that?
Top part.
No, when you auscultate, we have got areas, no?
Okay. It's around the aortic area.
That's the broadest area.
Usually, yes, sir.
Okay. It's not the broadest area, but it is the area where you hear it. Okay. So systolic murmur, possibly functional. Okay. Murmur in the neck is possible due to venous hum. Okay. So coming to the details of the murmur, tell me.
The murmur is
of hyperdynamic circulatory state. So tell me the points to differentiate. For 2 or 3 points you already mentioned regarding functional versus organic. You said it is in the base, there's no thrill, there's no conduction. Any other point you would like to say?
Usually systolic. It is usually systolic, not diastolic.
Okay. So your correct answer you are giving. Very good. So functional murmurs are never diastolic.
Okay, sir.
Functional murmurs have no thrill.
Okay.
They are never late systolic murmur. The late systolic murmur classically seen in mitral valve prolapse. Okay. There will not be any accompanying features of a heart disease, symptoms or signs. And it's always systolic, never diastolic. And it is here at the base. That means pulmonary area and aortic area.
Okay, sir.
And particularly the second heart sound in these patients will be normal.
Okay, sir.
The organic can be diastolic, can be systolic. And organic, there could be a thrill. Thrill means grade 4.
Okay, sir.
And once you say organic, it's always a organic problem, not a functional disease. Okay.
Okay.
And usually there will be other features of an organic heart disease.
Okay.
The murmur can be late systolic, pan-systolic, diastolic, mid-diastolic, any pattern can be there. And organic murmurs are heard over the mitral area, tricuspid area, aortic area, anywhere.
Okay.
And second heart sound will be commonly abnormal. So any gave functional murmur, you have to differentiate from organic murmur, and you have to be very definite that is functional or organic. In patients who are having anemia, it's better not to commit the patient having a valvular lesion. You correct the anemia and then only commit. Otherwise, some of the murmurs may be because of anemia itself. Okay. What is a continuous murmur?
It is seen throughout the cycle, systole and diastole, usually associated with fistula, heavy fistula.
Okay. Continuous murmur is a murmur that starts in systole, and the important point is it crosses the second sound. It need not be throughout the systole and diastole. It crosses the second. That's the important point.
Okay.
So one cause you said fistula, other causes. Suppose somebody gets a severe chest pain, following which a continuous murmur appears. What is the possibility you suspect?
Can be patent ductus arteriosus.
No. Listen to the question. Somebody is absolutely well, no murmur. He gets chest pain, then continuous murmur. What possibility you will suspect? Rupture of sinus of valsalva.
Okay, sir.
Okay. There are many other conditions producing continuous murmur: venous hum, PDA, aortopulmonary window, coronary arteriovenous fistula, and who are lactating mammary souffle. Pregnant people can have mammary souffle. Then what is a venous hum? This patient has a murmur in the neck. That could be venous hum. Venous hum is an example of continuous murmur.
Okay, sir.
Okay. Best heard in the neck. 2. 3. In the sitting position. And the peak of the murmur is end of systole. 4. When The patient turns head to opposite side, murmur increases. 6. When the patient turns head to the same side, decreases. 7. You put your finger above your stethoscope in the neck and try to obliterate the vein. The murmur disappears. Okay, so these are the features of a venous hum. So possibly this patient had venous hum also. Okay, so how do you plan investigation for this patient?
Initially, we need to check for the anemia. For that, we'll check for the serum iron ferritin levels, total blood count.
Yes.
Then HB content can be looked for. Then blood indices normally MCV, MCH, MCHC, etc. can be checked for. Then for the dysphagia, we can conduct an endoscopy, and manometry. Stenosis is strictly suspected. Then barium swallow can be done.
Any other investigation you plan? So we have an aim for investigation. Aim number 1 is to find out what type of anemia you have. So first investigation, in any case of anemia, is a peripheral smear.
Okay.
That will tell you whether it is normocytic, normochromic, hypochromic, microcytic, or macrocytic. Then you proceed further investigation. The peripheral smear also will tell you about platelets and white cells.
Yes,
and the peripheral smear also will tell you whether there are any parasites inside or outside the RBCs.
Okay, sir.
Okay.
Okay, sir.
So in the case of anemia, first and foremost investigation is peripheral blood. If you are allowed to do only one investigation, the patient cannot do any other investigation. Go for peripheral smear. But commonly we go for complete hemogram.
Yes, sir.
Okay. And what are the things you look for in the hemogram? You said hemoglobin.
Hemoglobin, RBC, total blood count.
White cell count, you mean?
White cell count.
Okay. What else?
Then the blood indices.
What are they?
MCV.
MCV.
MCH.
MCH.
MCHC.
MCHC. Very good. What else you look for?
Then platelet count.
Platelet count, correct. Platelet count, then first step is to do hemogram and then a peripheral smear. Third is for the iron studies. You already mentioned iron studies. Then we have to find out the cause of the anemia.
Yes, sir.
If it's iron deficiency, what's the cause? If it's B12 deficiency, what's the cause? So what are the investigations you plan?
If it's iron deficiency, we can find from the iron study, serum iron concentration, TABC.
So this particular patient had low hemoglobin, low MCV, low MCH, low MCHC, elevated platelet count, and then we'll go to the investigations now. So first step is hemogram, peripheral smear, iron study. Second step of investigation is to find out the cause.
Okay, sir.
So instead of going for barium studies, simple basic things. Stool microscopy. What are you looking for the stool microscopy?
Occult blood.
No.
Microscopy. If any parasites.
Which parasite is related to anemia?
Can be hookworm infestation.
Hookworm infestation. Second investigation, you rightly said occult blood. At least 3 samples to be taken.
Yes.
And depending upon the scenario, you go for upper GI or lower GI. The important point to be stressed is anybody who is above 40 years, if there is no cause for anemia, always think whether it could be malignancy of the stomach or colon.
Okay.
the two organs which can be the culprit area for the loss of blood. There could be other causes for the deficiency which has to be investigated specifically.
Yes, sir.
Okay, so hemoglobin is reduced. What do you expect about the RBC count?
Reduced.
Okay, MCV is reduced, MCH is reduced, MCH is reduced. Then you may find something called red cell width. What is it? We'll come to that. And peripheral smear you wanted, and this is a picture. So there is anisopoikilocytosis. What does it mean? What do you mean by that?
Difference in the size of the different RBCs.
So aniso means different in size. Poikilo means
shape. Difference in shape.
Okay. Pencil cells. Which condition you get pencil cells?
Iron deficiency.
Okay. Eosinophilia.
Allergic.
Allergy. Which allergy you are talking about?
Allergic rhinitis. Parasite. Okay. Parasitic. In case of parasitic infections, there.
Parasitic infections. Okay.
Yes, sir.
So that is all right. Parasitic infections. Now you want to do iron studies, you said. Which are iron studies you want to do?
Serum ferritin, serum iron concentration, total iron.
Serum iron is not commonly done. You go for ferritin. When you find ferritin below which level you call iron deficiency anemia?
No, sir.
12 milligrams. 12 is the cutoff. Okay. 12. Below 12 you call it as iron deficiency anemia. But if it is normal, what do you say?
We will check for TABs.
If it is normal, you must also remember that ferritin is a acute phase reactant. In any scenario where there is infection or inflammation, it can go up. That patient also may be iron deficiency. So based upon ferritin alone, you cannot say he is absolutely well. Total iron binding capacity, how does it help you?
In order to differentiate from nomocytic.
Okay. Total iron binding capacity indicates that if it is increased, it means there's deficiency of iron. Okay. And what is transferrin saturation showing? Transferrin is the saturation protein. So the saturation protein is not saturated. That means there is no iron to saturate it. So that's evidence for deficiency. Okay.
Yes, sir.
How do you account for the elevated platelet count? So there will be excess stimulation of the platelet precursors by erythropoietin.
Okay, sir.
So usually it is thrombopoietin, but here erythropoietin is stimulating the, which is a precursor. Precursor of platelet. You are right?
Agaricoside.
That's right. Agaricoside. So when it is excessively stimulate, so red cell distribution width, yes, it is increased because of what?
Not due to maturation.
Red cell distribution width means some of the cells are very small and some of the cells are very large. So the distribution width is increasing. How does it help you?
Immature blast, when there is more blast cell, immature cells RDW increases. So
No. So in a very close differential diagnosis for us with iron deficiency anemia is thalassemia, where you will find they also have hypochromic microcytic anemia, but red cell width will be very, very narrow.
Okay, sir.
So if you find red cell width is more than 16, that goes in favor of
Iron deficiency.
Iron deficiency anemia. That's a very important point for us to differentiate. This happens because of the different size and shape of this. Okay,
Okay,
so we have many conditions producing hypochromic macrocytic anemia. One close one is thalassemia. So how do you differentiate between the two?
RDW,
Mm-hmm.
then genetics
Genetics.
study.
We don't have genetics. We go for simple investigations. Okay.
Okay,
What we can do in our hospital, we can do. Look at the first one. Red cell with distribution. We already mentioned the difference between the two. Wide in case of iron deficiency, narrow in case of thalassemia. In both cases, you have hypochromic microcytic anemia. But if you look at the total RBC count, it is low in case of
Iron deficiency anemia.
Usually less than 3 million. Usually, no arbitrary value. At the same time, in thalassemia, you find the iron binding capacity is normal.
Okay, sir.
Okay, there's a synthetic problem there. Here it is iron binding capacity is increased, and transferrin is freely floating. It is not saturated in iron deficient anemia. Here, the thalassemia, it is normal.
Okay, sir.
And ferritin is low in case of iron deficient anemia, is normal in case of thalassemia. And as you said, iron can be estimated. Again, you can confirm. So, simple iron deficiency anemia versus thalassemia. If you look at the hemogram report, in the hemogram report in our hospital, we have the printout coming. You see RDW. Look at it, and you can deduce what is a possibility there. Also look at the RBC count that is coming there, and the proportion between MCV and the hemoglobin. It will go parallel in case of iron deficiency. There will be disproportionate change in case of thalassemia. So even without going for any genetic studies, we have enough number of indirect evidences whether you are dealing with iron deficiency or thalassemia. It's okay.
Okay, sir.
So what are the causes of iron deficiency states?
Parasite infections.
So look like this. You require iron. So if your diet is less, okay, 1, okay, 2.
Then blood loss of blood increase.
What are the sources of loss of blood?
GI bleed.
Okay.
If there is any hemophilia or diseases like that, bleeding disorders.
The common things, menorrhagia, bleeding hemorrhoids, occult blood, parasites. Okay. What else can produce iron deficiency?
Dogs.
If you have got too much demand, what a situation where you have too much demand?
Pregnancy.
Hyperthyroid. That's okay. So turnover is high, you will find it all becomes deficient. So, and it is absorbed from the intestine. So can there be any problems there?
Yes, sir. In IBDs.
If start from the stomach, go down. If there's achlorhydria, you will have iron deficiency anemia.
Okay,
so one way to treat iron deficiency anemia is to add vitamin C containing food, papaya, mango, pineapple, lime, guava, vitamin C containing foods, which will increase your absorption of iron. Zinc containing food, absorption of iron will increase. Suppose you have got H. pylori infection of the stomach. Again, one manifestation is
iron deficiency.
Iron deficiency anemia. If you have undergone bariatric surgery, you are bypassing your duodenum where from the drug is absorbed. Again, you will have problems. What are other problems in intestine which can produce decreased absorption?
There can be inflammatory bowel diseases, ulcerative
colitis, the colon, no? Those diseases affected the duodenum, basically.
Duodenum, short like short bowel syndrome.
Celiac disease is not very common in Kerala. Celiac disease is one. Okay. So different types of malabsorption states where there's a blind loops. Okay. So you can have iron deficiency. So decreased intake, excess demand, excess loss, diminished absorption, they are all factors that can produce problems. Okay. So what are the common causes of hypochromic macrocytic anemia?
Due to iron deficiency.
T standing for thalassemia, A standing for anemia of chronic disease, I stands for iron deficiency, L standing for lead poisoning, and S standing for sideroblastic anemia. Okay. How much iron do you require a day? Normal, non-pregnant.
200.
Pardon?
200.
200 what?
Milligram.
Normal, even for elephants, it is too much. Normal requirement is only 1 milligram per day for your body, but human body can absorb only 10% of your food. So if you are taking 10 milligram, 10% will be absorbed. That is 1 milligram your requirement. Maximum absorption in any scenario will not exceed 3.5. So 1 milligram is absorbed. At the same time, by the loss of epithelia, 1 milligram iron is lost every day. So the human body has got a balance between 1 milligram intake and 1 milligram of loss. So that is how it is balanced. Any situation where intake is less, loss is more, then you will have more problems. Okay, right. So 1 milligram per day is your requirement. So what is the mechanism of iron absorption?
First, the ingested iron is in the ferrous form.
Good.
And we need to, but the intestine, we need to absorb it in the ferric form.
That's fine.
So it is converted into correctly, I don't know.
Okay, so don't worry. You require a bit of acid there. Okay. So this picture, I don't have a pointer with me. This is a picture drawn with a hand, not from textbook. You can see on the left hand side, you see the epithelia, and there are red dots which are hepcidin, as it is saturating the cells. So it is a situation with high hepcidin state. So this hepcidin prevents the absorption of iron. Okay, go to the other side, you will find hepcidin is lacking. So just outside the cell, inside the cell, just go into the interior, you find a rounded shadows I have drawn with Fe. Can you see? Yellow
Yes,
color. That is the iron which is absorbed. So low iron stores suppresses hepcidin from liver. Okay. Chronic liver diseases, again, chronic inflammatory diseases like rheumatoid arthritis disease, there will be cytokine load in the body. It leads to hepcidin production from the liver, and this hepcidin leads to internalization of ferroportin, and it will produce anemia of chronic disease. So even though these patients have got normal amount of iron, you will find that they have got anemia basically. And this iron which is absorbed, you can see a butterfly shaped thing. That is the depiction for the transferrin. And then it is combined together and it is going to the different stores, maybe hemoglobin, maybe in the ferritin form, the myoglobin, enzymes, liver, and so on. Okay. So when you treat patients with iron deficient anemia, what are the chances of failing in your treatment?
There is increased hepcidin.
Increased hepcidin, that's right.
Low transferrin state.
That's the transferrin. Okay, No transmission. Any other?
Loss is more even when is a poor compliance.
Pardon? Poor compliance.
Poor compliance with that.
That's very good. Poor compliance. Why do people have poor compliance for iron? Because some people get abdominal pain, some people get diarrhea, majority of them get complaints of constipation. So they stop taking it. Okay, any other reason?
In the oral form, it may be malabsorption.
Oral form, it may not be absorbed because of concomitant oxalates, phytates, and food, which prevents the proper absorption. Any other reason? Okay. It requires the failure to respond, non-adherence you already said. Patient may be continuing to lose blood from different sources. Even if you give oral iron, it need not go in. If there is associated malabsorption, particularly situation like celiac disease, where there's no gross diarrhea is there, you may miss the diagnosis. If your stomach is having echlorhydria, and if you are not taking adequate amount of vitamin C, zinc, concomitant deficiencies, you may not get adequate response. And if the diagnosis is wrong, you treat a patient with hypochromic microcytic anemia as iron deficiency, patient may not respond. So you must also see what's a possible reason. In high hepcidin states, even if it will not be absorbed. So this is a situation where you have to give intravenously.
Okay.
So Vishnu Priya will take over now.
Okay, sir.
You have to wait. John, don't go, run away.
Yes,
Vishnu
sir.
Priya. Question number 1. Define refractory iron deficiency anemia.
Anemia not responding to treatment with iron supplementation.
Question number 2. What are the causes of refractory iron deficiency?
Sir, it can be due to malabsorption, non-adherence, incorrect diagnosis, and continuing blood loss.
So hemoglobin increment after 6 weeks of iron treatment, at least 100 milligram per day, it must show increase in hemoglobin. That's called as refractory iron deficiency anemia. Okay. So causes can be echlorhydria, absence of vitamin C, zinc, malabsorption. H. pylori should never be forgotten. It's a treatable option. We have celiac disease. Okay. Then what is iron refractory iron deficiency anemia? So it is a rare type of situation transmitted in an autosomal recessive fashion due to mutation of a gene, serine protease 6. It normally downregulates hepcidin. So if the hepcidin levels are normal or high and ferritin levels are normal, you suspect that it is possibly a iron refractory iron deficiency anemia. So only option is to give them intravenous iron. So when somebody is not responding, you have investigated widely, cause is not known, then you must think about this very rare possibility. Right? Yes. What is the limitation of doing ferritin in iron deficiency anemia?
Ferritin is an acute phase reactant, so even if in iron deficiency anemia, ferritin can be normal or increased.
If there is any other reason for the inflammation. Okay. What is ferric pyrophosphate citrate?
Sir, I don't know.
Okay.
Ferric.
Ferric pyrophosphate citrate is an additive in dialysate. Okay. that replaces
Okay.
5 to 7 milligram iron lost per dialysis. So during each dialysis, you are losing some amount of iron. Okay, so this drug directly delivers sufficient iron to the bone marrow to maintain haemoglobin, but do not increase iron stores, so there is no toxicity of iron. Okay, so how do you connect this murmur? There's a murmur here with iron deficiency anemia. Whenever you find a murmur in the base of the heart, aorta, aortic area, and there's anemia, how can you connect the two? Suppose it's an organic murmur, can you explain? So far the explanation was it is a functional murmur. If it is an organic murmur, what do you do? Systolic murmur over the aortic area.
Sir, usually seen in aortic stenosis.
Very good. And why is it so? Because we have got something called angiodysplasia of the intestine producing bleeding. Okay. Now tell me symptoms of iron deficiency anemia. Already he said there is fatigability, palpitation, dyspnea. Other than that, symptoms of iron deficiency anemia.
The patient can have syncope occasionally.
That's very good.
Pica is a presentation. Pica.
Okay, that you mentioned it. Anything else? Okay, so what is meant by pagophagia? Pagophagia is a specific thing for iron deficiency anemia. It is specific for iron deficiency anemia. Okay, so what is meant by pagophagia? Pagophagia means a type of pica. Pica means perverted appetite. People eat different things, but it can occur in many conditions like eating disorder and so on. But pagophagia is a specific symptom of iron deficiency anemia. Pagophagia, the term pica came from magpie. The other name for magpie is pica pica. Magpie is a bird that also collects non-eatable things. So that's how the term pica came. So pagophagia refers to someone who always eats ice. That is specific for iron deficiency anemia. Okay. And what next one is restless leg syndrome. Okay. So sorry. So next one is restless leg syndrome. Restless leg syndrome, not leg syndrome. So what is restless leg syndrome? It is a situation where patient is very restless. He has got uncomfortable feeling of his legs. He keeps on moving it and he keeps on walking. When he goes to bed, he cannot sleep because of his uncomfortable feeling of his lower limb. This is called restless leg syndrome. Sorry for the mistake of spelling. The third specific thing will be bituria. What is bituria? You are there. You are almost there. Come on.
Usually, high colored urine.
Urea and high colored urine. Okay, bituria.
Usually seen after taking beetroot.
Excellent. Good thinking, Very good. So people who take a lot of beetroot, they pass red colored urine is called bituria. That is seen in iron deficiency anemia. Any other symptom? Headache. Headache is a non-specific thing, but can be seen very high percentage of patients with iron deficiency anemia. You correct it, they become better. Okay. Exercise intolerance and dyspnea are the other symptoms. Okay, so what will be the differential diagnosis for phagophobia or pica? Pica, what is the differential diagnosis? Different
First
types
one,
of eating disorders can produce pica. What will be a differential diagnosis for your restless leg syndrome?
Sir, in psychiatry, there is a condition called restless leg syndrome.
Okay, so there is a condition. It can occur in CNS diseases. It can occur in pregnancy with leg cramps. And what will be differential diagnosis? Hypochromic microcytic anemia.
Thalassemia, iron deficiency anemia, sideroblastic anemia.
Okay. Okay, we already mentioned tails.
Anemia, chronic disease.
Tip for you. Okay. And what's the differential diagnosis of iron deficiency anemia, thalassemia, and anemia of chronic disease? You said TAELS. So how will you differentiate?
From iron studies.
Okay. So you have got investigations. So how will you differentiate among them?
MCD is usually reduced in all the three conditions.
Yeah, that's good. Very good. That's why we have said differential diagnosis. Okay. Red cell width will be normal in case of chronic disease. And RBC count is decreased in both iron deficiency and anemia of chronic disease. And binding capacity is increased in
Iron deficiency
very
anemia.
important point. And transient saturation is decreased. Ferritin is decreased. But look, that anemia of chronic disease, ferritin can be low. So the point is, if you look at a patient with hypochromic microcytic anemia, looking at ferritin alone, and you say it is low, you will think it's iron deficiency anemia. It may not be so. Before we conclude, can you tell a few more rare causes for iron deficiency, which you have not mentioned so far? Copper deficiency and B6 deficiency are two other situations where you must be careful when patient is not responding. Now, when you start the treatment for these patients, how long will you treat to get the response? After how many days you will get the reticulocytic response?
After 10 days.
4 to 7 days you must get the reticulocytic response. And when you expect the anemia to start improving?
3 weeks of treatment.
4 weeks. And when you say it's complete correction? Complete correction? 6 weeks. And after 6 months what happens? Storage of iron also become absolutely normal. Okay. Now tell me about how much iron is required for a normal pregnancy? Extra iron. 1 gram, 1000 milligram. Your daily requirement is 1 milligram. You require 1000 milligram during pregnancy. And during menstruation, how much is the loss?
100 milligram per day.
During menstruation, 1 milligram per day. Iron, okay. And hemodialysis, how much you lost? Hemodialysis, minimum 2, up to 5. That's why in patients with the hemodialysis, you need to supplement iron. In addition to the anemia of chronic disease, these people also have got excess blood loss. Now you want to treat this patient, what will you do?
First we will consider oral iron supplementation.
Yes, when you want to give oral iron, when you will give it? Before food, after food?
Usually after food, usually with vitamin C, along with vitamin C containing foods.
So commonly it is given before food, otherwise it will not be absorbed. So which are the situations where you find it is not absorbed?
give along with phytate containing food.
Phytate
Items.
containing food, yes. Oxalate containing food, yes. It will not go up. Okay. So,
Okay.
so which are the common sources of iron?
The most rich sources meat and
Meat,
green
green leaf vegetables, yes. Then for vegetarians, any other source you can suggest?
amla is a good.
Amla is a good thing. Yes. You can have dry fruits like raisins and dates.
Okay.
If they are not diabetic, they can have that also. Okay. So,
Okay.
and you give oral iron. And what are the indications for giving intravenous iron?
Then the patient cannot tolerate oral iron due to GI side effects. And if there is malabsorption,
Okay.
if there
You
is
already-
non-apparence,
You already said iron resistant anemia, it must be given.
okay.
And people who are having hemodialysis like situation where already hepcidin will be high, iron store is there, it's not utilized. In those situations, you have to give intravenous iron.
Okay.
Okay. So we are discussing today a case of simple state for iron deficiency anemia presenting as dysphagia and other complaints in relation to iron deficiency anemia.